For me to give these talks with my colleagues. We're going to change the order a little bit. Dr. Minnie Pathria is going to go first. She's going to talk about collateral ligaments and cruciate injuries. And then Dr. Donna Blankenbaker from University of Wisconsin. Minnie is from UCSD, University of California, San Diego. Then Donna Blankenbaker will talk about hip sports injuries. And she's from University of Wisconsin. And then Dr. Bill Morrison will talk about shoulder rotator cuff injuries, and then I'll finish up with meniscal abnormalities as well. So with that, I think we'll go ahead and get started. Minnie, so please give her a warm round of applause and we'll get started.
Thank you all for coming. I think all four of us thought we were the only people that were going to be in this room this afternoon, but I guess all your flights were canceled. Stabilizers in the knee, surrounded by this triumvirate of supporting structures. And we're not going to look at the extensor mechanism today, but we will be looking at the medial and posteromedial sides of the knee, as well as the structures that provide stability at the lateral side of the knee. And we're going to intersperse this with a few questions. So I'm going to start first with the cruciate ligaments. As you know, this concept of the double bundle cruciate is very popular with our orthopedic surgeons, some of whom are actually doing double bundle reconstructions of this ligament. This is the most commonly injured of the knee ligaments, comprising about 60% of all knee ligament injuries, and it makes up the majority of the ligament injuries that wind up going on to surgical reconstruction. And they get their name because they actually twist around each other as the knee goes into flexion, something that we don't appreciate on our standard extended knee MR images. Now, there are two main mechanisms of injury. The first is a pure anterior translation. This is actually rather uncommon to get a pure anterior translation injury. More often, the anterior cruciate ligament is injured through a mechanism that is called ALRI, or the anterolateral rotary instability pattern, where the tibia shifts forward more so on the lateral side than on the medial side, and it internally rotates. So this is a mechanism that has a very characteristic bone bruise pattern that I'm going to show you later, and that is the most common way that the ligament is torn. Now, some people like to diagnose partial tears frequently. I personally don't see an awful lot in my practice, and I make this diagnosis rarely. They're treated conservatively, and unfortunately we don't get surgical follow-up on these cases, so it's hard to actually improve our diagnostic acumen. But I like to see actual increase in signal within the anterior cruciate ligament substance on at least two planes before I make this diagnosis, because if you have a large effusion and fluid pooling around the back of the capsule, you may get some averaging, and some of the anterior cruciate can look bright on your sagittal sequences. So they're more common in the younger patient. They can involve either bundle. The anterior bundle partials are easier to recognize because that's a better defined bundle. Normally, the posterior bundle ones are a little bit more of a problem, so make sure that you confirm that something is going on your axial images. Now, for clinical imaging, the majority of anterior cruciate ligament tears that I see, because I have an adult practice, are going to be complete tears. There may be a few fibers that remain, but if you look carefully, they don't have continuity as they go from the femur to the tibia. And as you see in this patient, the tearing is going to be typically seen closer to the femoral side of the cruciate ligament insertion. And the findings that we see are going to be the same with ligament injuries that we have everywhere in the body, with discontinuity and gaps being visible, and caliber changes and changes in orientation and signal. This is another example. This one is a little bit less acute than the one that I just showed you. It doesn't have as much effusion or much edema in the ligament, but we can recognize that there is a stump of ligament that is not connected to the distal fibers, and it's very important to understand that the orientation of the cruciate typically changes when you have a complete tear with the distal more fibers becoming more horizontal. So the axis that we use for reference is known as the Blumenstadt line, which is the roof of the intercondylar notch, and our normal anterior cruciate would be parallel to or slightly vertical to that line. And this is the inclination that it frequently assumes, and it often scars into the posterior cruciate ligament in the more chronic cases, but you can recognize that a tear took place because of that mechanism. Now, if you look at this patient who has a tear, again closer to the femoral than to the tibial side, you'll notice that there are some fibers that are rotated. And it's important that you mention this in your report. And these fibers that are rotated can result in a few problems. They can result in what's called stump entrapment, where the patient has difficulty extending, and they can result in one other problem, and this is the first of your questions, is what other abnormality do we see associated with rotation or entrapment of a torn ACL? So here are some of your choices, and I will let the audience respond. What do I do? What? Oh, I have to read the choices? Okay. Which abnormality is associated with entrapment of a torn anterior cruciate ligament? Number 1, ligamentum mucosum tear. Number 2, formation of a cyclops lesion. Number 3, patellar tracking dysfunction. And number 4, adventitial disease of the popliteal artery. I have to read them for the virtual audience. I was wondering, are there blind radiologists in the room? Okay, very good. And that is the correct answer. The correct answer is that you can get a cyclops lesion. So be aware that this particular abnormality is seen not only in the post-operative anterior cruciate patient, but it can also be seen in patients who simply have a tear where the fibers rotate anteriorly. And some orthopedic surgeons feel that it's these rotated fibers that act as the nidus for development of a cyclops lesion even in the post-operative patient. So very good, and you all know that this is a low signal mass that we see at the anterior interval. Now, secondary findings can be very helpful for us with anterior cruciate ligament tears. There are many of them, and they're listed on this slide, and they include changes in the course of the PCL, some meniscal pathology that we're going to look at in a minute, and a variety of osteochondral abnormalities that we can see. So this is bowing of the PCL, and it's really related to anterior tibial translation. I don't find it a very, very useful sign. So which pattern of meniscal injury do you think is most common in patients who have an anterior cruciate ligament tear? And the choices are, number 1, a parrot beak tear of the lateral meniscus. Number 2, a medial meniscocapsular separation. Number 3, a vertical tear of the lateral meniscus. And number 4, a bucket handle tear of the medial meniscus. Da, 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 da. Okay, so that was a well-written question. So when I was training, I was told that the most common injury was going to be a medial injury to the knee, and we were all taught about O'Donoghue's unhappy triad. But we actually know now that the most common pattern are tears of the lateral meniscus, and that the correct answer is really a vertical tear that we see in the posterior horn of the lateral meniscus. So something to be aware of. Now, how does this happen? This is sometimes referred to as a Risberg rip. And what happens here is that you have a fracture or you have a tear of the anterior cruciate ligament, and you have translation taking place between the tibia and the femur. And this translation results in this vertical tear that propagates just anterior to the meniscofemoral ligament, like a zipper, as we see in this beautiful diagram taken from the literature. And I've drawn here what the mechanism is. The meniscus is tethered to the femur by the meniscofemoral ligament, and it's tethered to the tibia by the root. So when the tibia moves forward relative to the femur, it effectively pulls the meniscus apart along that plane, and we wind up getting this characteristic vertical tear. Not to be confused with the pseudo tear that you get when the meniscofemoral ligament comes off, but that's very smooth and only lasts for 1 or 2 slices. So this will propagate into the meniscus. The other problems that we get are a variety of osteochondral abnormalities. You can see that they're most commonly seen at the lateral side of the joint, with tibia a little bit more common than with the femur. So that's another very helpful finding that you're going to see related to that pivot shift mechanism that I mentioned earlier. So what happens here is that the tibia glides forward, impacts the femur, and you get this characteristic pattern of a central femoral osteochondral abnormality, whether it be a bruise or a fracture, and the same type of lesion taking place in the posterior tibia. So even though these are not related to each other or adjacent to each other when you image them, during the time of impact they were in direct contact with each other. Now, most of the time that we see these, a lot of people have a tendency to just call all bone marrow edema bruises, but there's a spectrum of osteochondral abnormalities that we can have. And one of the lesions that we see here commonly is an impaction fracture of the femoral condyle. This was first reported by Warren back in the 80s, and in his series, which was a plain film series, he only saw it in about 2% of patients. But we know now from MR that this is a common abnormality. And in one series, they actually reported an incidence of 30%. I think that's a little bit high, but this series was interesting because it also reported that those patients tended to have a poorer outcome. One of the few plain film indicators that you're going to get that somebody has had an anterior cruciate ligament trauma. Okay, we'll move now to the posterior cruciate ligament. This is injured less frequently than the ACL because it's quite a strong ligament, quite stout. It's one of the central stabilizers like the anterior cruciate, and it is well shown on MR imaging as a low signal arcuate shaped band that you should see on at least 1 and usually on 2 slices in the mid-knee. It also consists of bundles, and it depends whether you're a splitter or a lumper. The standard division is into 2 bundles, but there are newer concepts, including this one by Macris, who's actually divided it now into 5 bundles. And I think that's unnecessary, and certainly people don't treat these with doing multiple bundle reconstructions. The 2 bundles that you would normally see are smaller posteromedial and this bulkier anterolateral, or the anterior and central bundles combined together. And that's not uncommon that you'll get a little bit of increased signal between those 2 bundles. So as you look at this patient, this is at the time of injury, there was a partial tear. These bundle injuries can look confusing if all you rely on is your sagittal images. And as you look at the coronals, we can see that the medial fibers are abnormal. Notice that they have returned to a normal appearance on this follow-up, and the patient treated conservatively, whereas the more anterolateral fibers are preserved. So you can get single bundle injuries. Again, these patients are typically managed conservatively, and it accounts for a confusing looking appearance on your sagittal sequences. So I always like to use my axials and a little bit less so, but also the coronals, whenever I see abnormalities on the sagittal view, to try to figure out what proportion of the fibers of that posterior cruciate ligament are actually damaged. So mid-substance tears are most common. You can tear off at the femoral side, and as we'll see later, at the tibia, rather than tearing the ligament itself, there may be a fracture in here. But the most common location is going to be mid-substance. Now, don't confuse the little bit of gray signal that you get at the mid-substance from magic angle artifact for a tear. That is a small zone of signal, and it disappears on your T2 weighted images. Here's just another example of a patient who has a tear. Notice that this patient has some posterior shift of the tibia relative to the femur, and yet we still see some fibers that are in continuity. And the group from Duke emphasized this appearance where the PCL can develop a stretching type of injury without a gap. And this is analogous to what we see in the incompetent posterior tibialis tendon, where it's no longer functional, the fibers are stretched out, but you may not actually see a hole in them. The surgeons refer to this as a disruption in continuity. And this is a pattern that we need to be aware of, that the ligament can be quite incompetent. This is your next question. Which of the following is not a mechanism for a posterior cruciate ligament tear? And the choices are: number 1, hyperextension during sports; number 2, knee into dashboard injury; number 3, fall onto the tibial tubercle with a flexed knee; and number 4, jumping from height onto heel. Because this is not a mechanism. Correct. Okay, very good. So all of the other 3 are mechanisms, and depending on the kind of practice you have, if you have a lot of sports patients, you're going to be seeing the first type. If you do a lot of high-speed vehicular trauma, you work at a trauma center, you're going to be seeing the second type. And if you're dealing with more older patients, or patients that are just generally clumsy, then you're going to be dealing with the third type of people who fall. So let's look at these different mechanisms. In the hyperextension mechanism, the tibia translates anteriorly, but more importantly than that, it hyperextends. And the characteristic thing to note in these is that the bone contusions that you're going to see are going to be located anteriorly. So every time I get a knee MR and there's a lot of contusion at the front of the knee, the first ligament that I'm going to focus on is to go and look at the PCL and at the posterior capsular structures. And again, I mentioned that you can get a mid-substance tear or you can get an avulsive injury where the tibial insertion site or its footprint is pulled off of the tibial bone. And here is an example. And these can be surprisingly easy to overlook on the radiographs. We fortunately had a radiograph of this patient from earlier when he had been done for another reason, which was normal. And here he is at the time of his injury. And you can see that this thick sloping cortical structure or subchondral structure at the back of the knee corresponds to the PCL footprint and is not located in its normal position. It should really come and line up with that posterior tibial cortex. And here's what it looks like on CT and on MR. But sometimes we get surprised and we miss a subtle one of these on the plain film, and then you get your MR or your CT and you see this big avulsion fracture. The other mechanism, the knee into dashboard type of injury, pushes the tibia posteriorly. This is the same thing that happens if you fall and you land on your tibial tubercle with your knee in flexion. The tibia gets pushed backwards. Here, the tibial contusions, again, are going to be anterior, but the contusion on the femur is more variable. It can be located anteriorly, centrally, or posteriorly, depending on how much the tibia translated. So once again, when you see anterior tibial edema, you really should go and look at the posterior cruciate. And here we see an example of the more femoral avulsion type of injury where it's just been pulled off of its femoral footprint. So you can get rotary mechanisms, which are a little bit more complicated. Here the rotation is different than what we saw with the anterior cruciate. Here the tibia externally rotates and shifts posteriorly on its lateral side. And as it does this, it can lead to injuries involving these posteromedial supporting structures. These kinds of patients tend to have more posterior shift. If you're seeing a lot of posterior shift on the PCL, there is probably a corner injury that is associated with it. So let's move now to the medial side of the joint. Medially, we all know about this superficial medial collateral ligament. It's a band-like structure, very elongated and very well shown to us on our routine MR images. And it's the most important of the medial stabilizers, and it is responsible for between 60 to 80% of medial stability, depending upon what the exact position is of the knee. Now there's a smaller ligament that lies deep to it, which is the deep medial collateral ligament. It's a little bit grayer. It's not always clearly seen on MR imaging. Its insertions are much closer to the articular surface, than the thicker superficial medial collateral ligament. We should know about it though, because again, it is important for stability. It augments the strength of the superficial, so when both are torn, you tend to have a little bit more valgus instability. And in this diagram from an article taken by de Messenier, note that there is a bursa that's located between that superficial and that deep ligament. So seeing a little bit of fluid between them does not mean that there has necessarily been an injury to the medial collateral ligament. The mechanism is several. The first mechanism we'll talk about is a pure valgus injury. This results in a failure of the medial collateral ligament, usually above the line of the tibial articular surface, closer to the femoral side, and it results in compression injury of the bone laterally, which can take the form of contusions, or it can take the form of subchondral or osteochondral fracture, as we have in this particular patient. The other mechanism is again rotary. Here the tibia externally rotates but shifts forward medially. And in this mechanism, along with the medial collateral ligament tearing, we may get anterior cruciate ligament tearing, we may get meniscal tearing, and we also see abnormalities with tearing in the posteromedial corner structures. So this is the mechanism that is responsible for the very famous but not that common O'Donoghue's unhappy triad, which is the constellation of ACL, medial meniscus, and medial collateral ligament trauma. So let's take a look at a couple of patients. Here's a patient with a medial collateral ligament injury. The superficial ligament is bright and thickened. The deep meniscofemoral portion is bright and thickened, and we have edema on the opposite side. And again, the findings in a ligament tear anywhere in your body are going to be exactly the same. Now, some people like to use superficial edema to diagnose grade 1 strains of the MCL. I think that that is very nonspecific, and there are many reasons why you might see fluid overlying the medial collateral ligament. Simple things such as a leaking Baker cyst that you can appreciate on MR, but many patients, especially older women who might have some venous stasis, will often have superficial fluid along their anteromedial knee. So it's not a very specific finding, and I like to see signal changes within the ligament myself before I make the diagnosis. So here we have clearly see intraligamentous signal, and it's nice to confirm this on your axial images. I like to use the axials for signal and also for size, because this ligament rotates a little bit, so you may get some slices where it looks thicker than you might expect. It's always easy to find the medial collateral ligament. Just look for that bend in the femur between its flat anterior and its more sagittally oriented posterior portions, and the MCL overlies that particular structure. Look at both the deep and the superficial. One of your clues that you might be dealing with a deep injury is this characteristic pattern of edema, which is located well below the physeal scar, which is around where the superficial would be inserting. The deep inserts about half to 2/3 of the way up, and you'll see this characteristic edema. Sometimes you may even have a fracture in that area, and that's a good clue that there's been an injury to the meniscofemoral portion of the medial collateral ligament. Now, in terms of grading, the clinical grading system relies on laxity, and I don't think we do very well on MR correlating with that clinical grading system, because we don't usually see patients who are wide open on our resting MR, which is obviously going to be an examination that is done without stress. So the typical MR grading system that's used is superficial edema, partial tear, and complete tear, but be aware that our grading systems only look at the superficial. They don't consider the deep components or the posteromedial corner stabilizers, and that there is quite a poor correlation between MR grading and clinical determination of laxity. So let's take a look at this question. Which of the following is an indication for surgical repair of a torn medial collateral ligament? Laxity greater than 1 centimeter on valgus stress, Pellegrini stieta ossification, entrapment of medial collateral ligament fibers, and associated rupture of a Baker cyst. Okay, so I think I can understand why a lot of people pick number 1. The correct answer is number 3. It's interesting, even with gross laxity, that these patients have very good non-surgical outcomes. So even the high-performance athlete with a high-grade MCL is generally going to be managed conservatively unless they have an associated meniscal tear that needs to be repaired or they have an associated cruciate ligament that needs to get reconstructed. But entrapment is an indication for surgical repair, and it is not common. I'll show you a few examples. The medial collateral can get entrapped, much like a Stenner lesion, and it can get entrapped inside the joint, entrapped inside a physis. It can come out and lie superficial to the pes tendons, or it can get entrapped inside the deep medial collateral ligament or on top of the semimembranosus. So a number of different places, and the usual clue to it is that your medial collateral ligament becomes like a corkscrew, and it typically will end somewhere around the joint line. You don't see the distal fibers. So when you have that kind of a finding where it's corkscrew and you don't see the distal fibers, you need to consider this diagnosis. And here we have an example where the MCL is now entrapped deep to the anterior arm of the semimembranosus, but a number of different types of entrapment have been described. Here's another example. It's entrapped, and then on the sagittal images, there it is heading backwards and getting stuck. These are not going to heal. The patients stay lax. So at least at our institution, these are considered indication for immediate surgery. Now let's go behind the medial collateral ligament and we'll look at the posteromedial corner structures. When you see an MCL tear, you want to go over to your axials and use that and figure out where the tear is extending. Just like when you see a slap tear, you look and see where it is extending. So this posteromedial corner is important for providing stability against valgus, especially when the knee is in full extension. So the structures that make up this area are complex, and there's some disagreement in the literature, but the major thing that we're going to focus on today is the posterior oblique ligament and the semimembranosus. These interdigitate with each other, and they are right behind the medial collateral ligament, along with the gastroc and the adductors, a number of different structures back in this area. Now, the posterior oblique ligament was considered part of the medial collateral ligament for a long time, but it's now considered a separate structure. Its fibers are oriented more obliquely, which is why it gets its name, and we can recognize it on MR as this sort of punctate collection of low signal bands located behind the bend of the femur. And as you go down the knee, these bundles will become more obvious to you. As you're high, they're confluent with the MCL, and as you work your way down, the bundles will separate. And we see injuries in this area in patients who have cruciate trauma or patients who have medial collateral ligament trauma, isolated, and it spreads into this back region. So the injuries can involve the posterior oblique ligament, the semimembranosus, or result in meniscocapsular separation. So we're going to now turn and look at the last set of ligaments we're going to consider, which is the lateral side. And I usually like to work this going from front to back, starting with the IT band, then the fibular collateral ligament, and the biceps not shown on this diagram that inserts with it, and then work my way around into the posterolateral corner. So let's start up at the front. And one of the injuries that we see at the front related to the lateral capsular structures is the Sagan fracture, this characteristic centimeter-long avulsion fracture seen at the lateral tibial border. And your next question is, what is the significance of this Sagan fracture? And the choices are, number 1, there's a high risk of perineal nerve dysfunction. Number 2, there's a high rate of non-union of the fracture fragment. Number 3, there is a strong association with patellar dislocation. And number 4, there is a strong association with anterior cruciate ligament tear. I think Mark knows the answer to this one. Excellent. Okay, that is the correct answer, is the one that has the highest score here. And there is a strong association of the Sagan fracture with anterior cruciate ligament tears. In some articles, they suggest 100% association. Some go down to 90, but it's very strong. You can also see Sagans with posterior cruciate ligament trauma, but it really is a strong indicator that there is some abnormality likely to be present within the cruciates. What exactly causes this fracture is debated. There are a number of different postulated mechanisms, including the iliotibial band, the capsular ligament, and then smaller structures coming from more posterior, such as the short arm of the biceps. Behind that, we come into our fibular collateral ligament. This is a stout ligament. It's easily seen on MR, but if you're using your coronal images, you may not see it all on one slice because it angulates posteriorly as it heads downward. This is an image I pay a lot of attention to on MR. I always like to find this triangle of structures when I'm reading my knee studies. The biceps located posterolaterally, the fibular collateral ligament at the apex of this triangle, and then the deepest structure here is the popliteus. And if you find this, it helps you sort out as you're going up and down exactly what is injured in your knee. Here we see an example of a patient with an anterior cruciate ligament tear who also has an injury to their fibular collateral ligament. It is typically injured, like most of the structures around the knee, at its more proximal side near its femoral insertion. It can be injured distally, and when you see that, you also want to look at the adjacent biceps tendon. The biceps tendon is not that frequently injured without there also being an injury of the fibular collateral. And here we see a patient where that entire complex has been avulsed from the lateral border of the fibula, and the edema seen in that triangle of structures that I mentioned earlier. And we'll finish up just in the last minute by looking at this posterolateral corner. This is a very complex anatomic region, and this is an image taken from Dr. Laprade's excellent article on this area. And I'll just emphasize a couple of things that we want to look at. The popliteus is the deepest and most important structure, and at our institution, it is the only part of the posterolateral corner that our surgeons actually reconstruct. So you really want to pay attention to the popliteus, make sure that there isn't an avulsion of the popliteofibular ligament or an avulsion at its femoral insertion site. The other structures that are back here are rather thin, and they're hard to visualize directly on MR, and we often infer that there is an injury here just by seeing that there's disproportionate edema in that posterolateral corner area and disruption of the soft tissues in the triangle that I already illustrated to you, and we wind up having to leave it to our surgeons to do a good examination, sometimes under anesthesia, to determine how much instability is present in this area. You can see this popliteofibular ligament quite consistently. Sometimes you'll see it best on coronal, and on other cases you'll see it best on your sagittal images. Here's a nice example showing you an injury of that popliteofibular ligament. So that's something that you really want to look for when you're doing your MR examinations. For completeness, I'll mention some of these other structures, but they're so wispy thin that they really are not visible to you on MR, and it's very difficult to determine that they have been injured on MR. And this is the last question that I have, is which fibular fracture pattern indicates that there's been injury to the posterolateral corner? And your choices are, number 1, a transverse fracture of the superior tip. Number 2, a comminuted fracture of the fibular head. Number 3, an oblique fracture of the lateral fibular head. And number 4, a spiral fracture of the proximal fibular neck. Okay, so that this was a little tricky question. This oblique fracture of the lateral fibular head is caused by the fibular collateral ligament in the biceps avulsing it. The correct answer for posterolateral corner is a transverse fracture just limited to the tip of the fibula, and this is known as an arcuate fracture. It's a small fracture, but this is where the arcuate ligament, the fibulofibular ligament, and the popliteofibular ligament all insert, and it's very characteristic of a posterolateral corner injury to the knee. So when you look at these fibular fractures, this is the one that you want to pay attention to. The oblique laterals are telling you there's something wrong with the lateral capsule, but it doesn't have to be the posterolateral corner ligament structures. So with that, I am finished. I do have a question from our virtual audience that I don't know the answer to, that I'm desperately trying to ignore, but Mark won't let me. So the virtual question that I have is, how do I differentiate ACL partial thickness tears from severe sprains? And the answer to that is, I think that a severe sprain is the same as a partial thickness tear. I don't distinguish sprains from partial thickness tears in my dictations. In fact, I don't dictate sprains ever in my reports. So I think it's the same lesion. So I would dictate a partial thickness tear. You might try to say how many of the fibers are involved, involving less than a quarter of the fibers, involving more than half of the fibers. I try to give some idea of the volume of fibers that are disrupted. But as I said earlier, our surgeons don't fix them, we don't get follow-up, so it's hard to get any better at it. So with that, I'd like to thank you all very much for coming and your attention.
Well, with that, I introduce our next speaker, who is Dr. Donna Blankenbaker from University of Wisconsin, and she will talk about the hip.
All right, good afternoon. Thank you for all hanging in there. Well, the topic that I was given was to discuss the hip labrum, so that's going to be the entirety of our discussion today. So what I thought we'd do is review the normal imaging appearance of the acetabular labrum, briefly discuss the imaging techniques, and then move on how to diagnose labral tears, and then we'll end up wrapping up with discussion of the pitfalls in diagnosing labral pathology. So we'll just remember that the hip is a ball and socket joint. Now the labrum will extend out from the acetabular rim, and inferiorly we have the ligament, or the transverse ligament, that attaches anterior to posterior, and later on we'll talk about those pitfalls that can occur here at the junction with the transverse ligament and the labrum. Now the labrum, it consists of fibrocartilage, and it's variable in shape. It's thinner anterior inferiorly and gets thicker superiorly, and the thickest portion is posterior superiorly. Signal intensity is typically homogeneously low signal on all pulse sequences, but as we age, we can have increased intrasubstance signal. And we just also need to remember the labral chondral junction. This yellow arrow nicely depicts that area, and we need just to be careful to recognize this structure, that we don't overcall labral tears at this location. And here's just an example of the normal triangular appearance of the labrum, whether you're looking on a sagittal, coronal, or axial acquisition. As you can see, in the majority of patients between 10 and 19 years old, it's triangular, but as we age, it can become more rounded. So just keep that in mind. Now, the function of the labrum is thought to increase stability of the hip joint by deepening the acetabulum. Therefore, you get resistance of lateral and vertical translation. Also, it helps to seal the joint and therefore provide fluid lubrication and maintaining synovial fluid pressure, as well as preventing direct contact of the two joint surfaces. So some of the imaging techniques that can be performed is MR arthrography, whether direct or indirect, conventional MRI, CT arthrography, as well as sonography. Now, the majority of this talk and how we're going to discuss the technique is going to be related to direct MR arthrography. So our first question is, and there's no right or wrong answer, is which imaging technique do you use in the evaluation of labral pathology in your practice? A, direct MR arthrography, B, indirect MR arthrography, C, conventional MR, D, CT arthrography, or E, sonography. And if some of you wondering, 20 seconds seems like forever, it's for our virtual attendees. Give them time to stop cooking and run over and mark. I hope they're all baking cookies. All right, so it looks like the majority of you are doing direct MR arthrography. So let's just discuss the MR arthrography protocol. Now, the workhorse is going to be the T1 fat suppressed sequences, the coronal, I really like the axial oblique, and then these sagittal sequences. Now, when we think about what type of parameters do we want to use, we need to have as small a field of view as possible, as well as a thin slice thickness, ideally a 512 by 512 matrix, and using some type of surface coil, and we use the cardiac phase extremity coil. You need to obtain T1 weighted sequences without fat suppression, and the reason for this is to assess the bone marrow as well as look at the surrounding musculature. Also, you need to include a fluid sensitive sequence, and the reason for this is to look at, again, at the bone marrow, looking for stress fractures, look at the changes around the muscles and musculotendinous regions. And then you may want to consider adding a proton density weighted sequence. I like the sagittal sequence, therefore allowing me to assess the articular cartilage. What's the role of radial imaging for the labral assessment? In the literature, it's shown that we don't have any increased accuracy in detecting labral pathology by performing this additional sequence. It is helpful in assessing changes of femoral acetabular impingement, as we can look completely around the hip articulation, looking for subtleties, especially in cam-type impingement. We should briefly review the injection technique. In the majority of patients, we inject the hip under fluoroscopic guidance using an anterior lateral approach, a 22 gauge 3.5 inch needle. My target is going to be at the lateral aspect of the head neck junction and just go in about 4 millimeters, go down and contact bone. What's the cocktail? There's numerous ways to perform this injection technique. Overall, I put everything in a 20 milliliter syringe, but you can do it multiple different ways. And I typically inject anywhere from 12 milliliter to 15 milliliter total, or if the patient has discomfort before that, I'm going to stop the injectant. Now, it's also important to include anesthetic into this cocktail. And I use a short-acting and a long-acting anesthetic, and therefore, if these patients get relief from this intra-articular injection at the time of the MR arthrogram, and they have intra-articular pathology, the surgeon is going to be more apt to operate on those patients versus if they have no relief following the injection. Our surgeon is not going to operate on these individuals. They're going to be looking for other sources of their pain. Let's now look at some other imaging techniques that have just routine conventional MR imaging, and ideally you can also nicely assess the labral pathology. Same patient you can see here with their anterior superior labral tear. Well, how good are we with MR arthrography for labral tear detection? Have a very high sensitivity, accuracy, and specificity. And looking at the older literature with conventional MRI, we're not very good. However, recent studies have shown MRI similar accuracy to MR arthrography and using either 1.5 or 3 Tesla imaging. So, and we'll look at another paper and further assess which you may prefer. And this is the study looking at a meta-analysis of 19 different papers. And what they found was that both MR and MR arthrography both had moderate sensitivity and specificity, with MR arthrography superior to conventional MRI as far as higher sensitivity for detection. What about the role of indirect MR arthrography? So you perform an intravenous injection of gadolinium, you go out and exercise these patients, and some centers, they're doing this. We currently are not. And in the study by Zlatkin and colleagues, they had 13 labral tears. Of these, 100% were detected on indirect MR arthrography, and only 85% were detected on conventional MR imaging. However, they did not compare that to MR arthrography in the direct form. CT arthrography can also be useful for detecting labral tears, especially for those patients who cannot go into the MR magnet, and also high sensitivity, specificity, and accuracy, and also it would be ideal for assessing the articular cartilage. What's the role for sonography? We're only able to assess the anterior superior aspect of the labrum, and the sensitivity, specificity, and accuracy are much lower, and therefore has a less diagnostic ability than MR arthrography. Let's now move on to more characteristics of labrum and how we detect labral tears. So some of the causes that we see that produce labral tears, the hot topic of femoral acetabular impingement, whether you have CAM morphology, so that osseous excrescence anywhere from the anterior to lateral aspect of the femoral head-neck junction, or the pincer morphology. We also see labral tearing following traumatic injuries, whether the patients had prior posterior hip dislocation or even minor twisting. Also, we see labral tearing with patients with osteoarthritis, acetabular dysplasia, and sometimes there's no cause that we can elucidate. How do these patients present? Symptoms are that of a sharp catching pain. They may have popping or locking, as well as a dull activity-induced or positional pain, or may complain of deep anterior groin pain. The physical exam findings are that of a positive impingement sign, or pain with flexion, abduction, external rotation position. So our next question, what is the diagnostic feature of labral tear seen on MR arthrography? A, labral thickening. B, increased intralabral signal. C, contrast within the labrum. D, iliopsoas bursa communication. So start your polling. Kind of excited. It's too bad I don't get to vote. All right, great. So the answer is C, contrast within the labrum. We'll go ahead and review these other entities as well. So when I look at the labrum, I have a checklist of how I go through this. So first off, I look at the morphology. Is the labrum triangular in shape? Is it thickened? Is it distorted and irregular, representing a labral tear? Does contrast extend into the labral substance, representing a tear, or does it extend between the labrum and the acetabulum, representing a labral detachment? Now, oftentimes the words tear and detachment are used interchangeably, especially in the orthopedic literature. Also, what about this overall signal intensity within the labrum? If you have increased signal representing mucoid degeneration, and typically it's also thickened. Now, there's been multiple classification systems that's been described in both the radiologic and orthopedic literature, and the two really do not correlate, and therefore I think it's imperative to maybe just be descriptive in what you're seeing on imaging. Are the margins irregular, representing fraying? Is there a simple tear, whether it's partial thickness? Do you see high signal extending partially across or within the labrum, or full thickness, a through and through tear? Or is it just distorted, abnormal, then a complex tear? The next question is, what is the most common location of acetabular labral tears? A, anterior inferior. B, anterior superior. C, postero-superior, or D, postero-inferior. Very good. So the majority of you said 75% that the tears occur anterior-superior, and that is correct. So as we already said, the reason that these tears commonly occur here, or that's also where there's changes commonly that we see with femoral acetabular impingement. Now, posterior tears do occur. Typically, they're in the younger patient population. Also, we see it higher in athletes, and it's due to this loading in a flex position, high performance soccer players in which they're going to get a little bit of subluxation. We can also see it following posterior hip dislocation and also higher in the Japanese population. Now, I do believe that it's important to discuss the tear extent, as it's helpful for the orthopedic surgeon in counseling those patients for, first off, what the surgical outcome would be, as well as even to guide rehabilitation. Now, you can either use a clock face with 3 o'clock anteriorly, whether you look at the right or left hip, but you really need to know what your orthopedic surgeon is using. And therefore, a better terminology may be quadrants. So our anterior superior quadrant, posterior superior quadrant, anterior inferior, and posterior inferior. I typically use both. I'll say the tear is anterior to superior, and then in parentheses I'll say extending from 1 to 3 o'clock. Therefore, everybody's on the same page. Now let's look at some examples. Here we have increased intrasubstance signal. It's not as bright as fluid, slightly a little thickened, maybe a little rounding here of the tip, representing mucoid degeneration without focal discrete tear. In this large anterior superior labral tear, the patient went on for arthroscopic surgery. And here we can see in this patient, this is the femoral head, here's the acetabulum, and here's our large labral tear that we saw on imaging. And we'll also notice that here's the articular cartilage. It's completely devoid here, and here's the margins, which are irregular. And it's something to force yourself to look for on your MR images, as patients with labral tears, about a third of those are going to have adjacent cartilage degeneration. In this patient, we start off looking at morphology. We don't have the normal triangular shape. It's distorted. We have high signal and fluid-like signal extending out horizontally in this patient with an anterior superior labral tear. In this 42-year-old woman with hip pain, we look at the morphology. Well, the morphology is pretty good, looks triangular. We have high signal extending out laterally in a horizontal manner. And then we look at the axial oblique images. It's distorted and irregular. This is the patient's arthroscopic video clip of their labral tear, and we can see the extensive tear that the surgeon at this point is excising, and there's also some synovitis here within the joint. Young patient, he's a runner coming in complaining of hip pain. First off, we'll notice there's these prominent osteophytes at the femoral head neck region, and here's a horizontal labral tear and associated partial thickness cartilage loss of the acetabulum and femoral head. Now, a cause for labral tearing is the cam morphology. So here we have the decreased offset of the anterior femoral head neck junction and the associated labral tear. Now, with cam morphology or cam impingement, first off, you're going to classically injure the articular cartilage, followed by labral tearing. This is a 22-year-old athlete with catching and sharp hip pain. And we see that there's abnormal signal, kind of intermediate on our conventional MRI. And our surgeon then ordered an MR arthrogram to further evaluate this. And an MR arthrogram was performed, and we'll notice that it's not as bright as fluid. And so what does it mean? Is it filled with granulation tissue? Is it partially healed? Is it healed? And this is only 3 weeks in between the two examinations. And looking at the literature, what has been shown that near a third of tears that you can have signal intensity less than gadolinium or fluid. So just kind of keep that in mind, and therefore closely scrutinize your T2 or your STIR sequences. I really like to look at the high signal on those sequences, as it can help my diagnostic confidence. Even these tiny little tears, you need to closely look at all your imaging planes looking for these tiny tears, as they can be significantly painful and producing problems. What about this individual? Well, definitely not normal. We can see that there's a shallow acetabulum, uncovering of the femoral head, and coxa magna, and there's extensive thickening of the labrum, extensive tear extending from the anterior superior to the posterior superior quadrant. Now, the surgical techniques for treating these patients with labral tears is either debridement or repair. In the majority of patients that we see, they're complex tears, and therefore they'll undergo surgical debridement. If it is a simple tear or a detachment and a young patient, then surgical repair is performed. Well, what about the postoperative labrum? So now we have all these young patients who've had labral tears, and they have debridement or repair, so they're now back out doing their activities, and a year or two afterwards, they're coming back with new hip pain. So in this patient, we see some irregularity of the margins representing fraying. So what should we expect after surgical intervention? Well, the normal postoperative appearance is going to be a shorter labrum following resection. Well, how can we tell if there's a new tear? We looked at this and we evaluated that in order to diagnose re-tears on the patients who have had prior labral resection, there's three things we should look for. One is a new line to the labral surface. Two, an enlarged or distorted labrum. And three, if you see a new paralabral cyst, then you know that there has been a new tear. Let's just look at an example. So this is the first MR examination in this patient, and here we see a small superior labral tear here on our coronal fluid sensitive sequence. They had interval surgical excision, and the patient comes back with new hip pain, and here we have a shorter appearing labrum. And on our axial oblique, we have a new line to the surface that wasn't present on the pre-surgical exam, helping us to make a confident diagnosis of a re-tear. What about in this case? So what is the most likely diagnosis? A, iliopsoas bursa. B, nerve sheath tumor. C, hematoma. Or D, paralabral cyst. All right, so good job, you guys. So D is the correct answer, a paralabral cyst. And if we just look at these images, you do see this big fluid-like collection. It's located lateral to the iliopsoas tendon, and we see this neck that extends toward the anterior labrum. And here on our T1 fat-suppressed image, it's filling with gadolinium, and therefore we know it's a paralabral cyst, and they have a labral tear. Now, paralabral cysts are typically extra-articular, and whenever you see a cyst-like structure around the acetabulum, be closely scrutinizing the labrum for a tear, as in this case. And here's the same patient on ultrasound of what it would look like. Here, longitudinal image, we have our acetabulum, our femoral head. Here's the paralabral cyst, and there is the tear, as our labrum should normally be echogenic. In this patient, we can see a small posterior paralabral cyst, so kind of unusual. Here we're thinking all these tears occur out anteriorly, so it really makes us focus and look at the adjacent labrum, and we can see this posterior labral tear. Next question, what is commonly found in central iliopsoas impingement? A, superior labral tear. B, iliopsoas bursitis, C, snapping iliopsoas tendon, or D, anterior labral tear? So this is a good question, Minnie. We're kind of all over the board. How many of you have ever even heard of central iliopsoas impingement? Can I see hands? Does anybody want to admit that they've never heard it? Okay, a couple out there. Well, I hadn't until a couple of years ago either. So that's our answer is anterior is associated with an anterior labral tear. So let's just talk about central iliopsoas impingement. This is an isolated, direct anterior labral injury, and what occurs is you have an intimate relationship between the iliopsoas tendon and that far anterior labrum at the 3 o'clock position. And what this suggests is you have an abnormality in the overlying iliopsoas tendon, whether it's really taut. Is it spastic tendon? Is it adhering down to the anterior labrum, or is it due to iliopsoas hypertrophy? Well, what's the significance of central iliopsoas impingement? So you diagnose a labral tear on your MR examination. The surgeon goes in to arthroscopically repair or debride the labrum, and they go in there and they see that the iliopsoas is thickened and kind of rubbing up against that anterior labrum, and you have synovitis there. So instead of just fixing and paying attention to the labrum, they'll also perform a central iliopsoas tendon release. So what they do is they'll cut the tendon at the level of the anterior acetabular rim. So that's kind of why it's important. Therefore, we looked at this, and can we see features, and can we preoperatively make this diagnosis? We looked at numerous features, the size of the tendon, the signal intensity, if there was any associated bursitis. And the only feature we found is that if you have an isolated tear far anteriorly from the 2:30 to 3 o'clock position, that this is associated with impingement. And therefore, at least I'll suggest that can be seen with central iliopsoas impingement. So in this patient, here's the femoral head, here's the labrum that's torn, and here's the thickened iliopsoas tendon that was just kind of plopped down and just kind of irritating the anterior labrum. Let's now move on to pitfalls in diagnosing labral tears. The question is, what is an MR imaging feature seen with a sublabral sulcus? A, paralabral cyst. B, depth more than the entire labral thickness. C, linear shape. Or D, adjacent cartilage damage. All right, so it looks like B and C are winning, and the correct answer is C, linear shape, and we'll go through these as well. That'll make more sense. So typically they should be linear in shape. So let's just talk about the sublabral sulcus. Well, the posterior inferior sulcus is found to be a common finding. The anterior superior sulcus still remains controversial. Some people believe that this is a healing tear. Looking at the literature by Sadek and colleagues in AJR back in 2006, 25% of their 120 patients had sulci, most commonly in the anterior superior and posterior inferior locations. In the study by Studler and colleagues, they had 10 patients that had these recesses or sulci. These are the locations. They found 7 at the anterior inferior portion in which they had no tears. As we kind of march up, they had 2 clefts and 2 tears, 1 cleft, and now we're starting to get into a lot of tears, and way up high in the anterior superior portion, 0 clefts and 20 tears. What they found out, there were these recesses or sulci. They should not have high signal extending into the labral substance. They should not be full thickness, and I kind of use a 50% rule. If it extends greater than 50% across the labrum, that's going to be more indicative of a tear. Abnormal, you should not have abnormal labral signal. You shouldn't have adjacent cartilage defects or bony abnormalities or paralabral cysts. This study, however, did have a selection bias as all these patients were symptomatic. Let's look at an example of a posterior inferior labral sulcus. As I mentioned at the beginning of the talk, this is created by the junction of the transverse ligament and labrum, so just be careful of this pitfall. Recognize that this is just the normal cleft there, and be careful of not overcalling labral pathology. Here's an example of a sublabral sulcus. Should, as I already said, extend less than 50% across the labral base. It should have smooth margins, should not be irregular, should also be shallow and narrow neck. Let's look at this example. So 2 sequential images. At first, when you first start to look at this, the neck looks a little bit broad. Looks like it extends a little bit greater than 50% across. The next image, we can see it's through and through, and therefore this is a tear and not a sulcus. This 17-year-old with left hip pain, he did get pain relief with intra-articular anesthetic. Let's look at these images. Our axial oblique images, we do see some high signal, probably a little bit too deep. We look at the subsequent sagittal images, and it's extending a little bit and extending a little bit backwards. In the subsequent image, we see it's distorted and irregular, and therefore this is a tear. Now, in the majority of patients that we see, most of the cases are tears and not sulci. And also, it's helpful too by putting in the anesthetic. It can help the surgeon of whether they need to perform arthroscopic surgery. And the final pitfall is that of the obturator externus bursa. This has been shown to communicate with the hip joint in 5% of arthrograms, and this is a normal anatomic variant. Now, the big thing is to remember that this may mimic a paralabral cyst, and therefore I've seen many individuals say, oh, there is an associated labral tear. And remember, labral tears are rare to have in that anterior inferior quadrant, so just remember this as a normal variant to be thinking about. So, in conclusion, what we've discussed is MR arthrography remains the workhorse at this time to assess the hip labrum, and it's the anesthetic portion at the time of injection that is the key to many ordering providers. When we diagnose labral tears, it's important to start out with the morphology. Is it triangular in shape? Is it blunted? And also look at the high signal. Does the high signal extend within the labrum or beneath the labrum, representing a detachment? Also keep in mind with iliopsoas impingement, that is when you're going to see those far anterior labral tears, typically at the 3 o'clock position, something that we may want to suggest ahead of time. And then also just remember the pitfalls. Thank you very much for your attention.
So we're going to take a 15-minute break. I apologize not for announcing that before. So we'll start back in 15 minutes, and Dr. Morrison will talk about rotator cuff, and then I'll finish the session with a discussion of menisci. So 15 minutes, and we'll start about, what time is it? So we'll start at 5 till 2. will go ahead and get started again. It's my pleasure to introduce Dr. Bill Morrison from Thomas Jefferson in Philadelphia, and he's going to be talking about MR of the rotator cuff. Bill.
Thank you, and I'd like to thank Mark for allowing me to see what RSNA looks like Friday afternoon. I really appreciate that. Thank you. And as part of the partnership of RSNA, they've partnered with the NSA, so Mark can actually see you all at home in your virtual meeting, so please wear something appropriate. You can access this after I get back home at our website on this link here. So first I just want to talk a little bit about positioning and protocol, and these are available, and thank you Wasim Khan, our former fellow, who developed these protocols for our website. So you can go to these and download them from there. So it's important to go all the way through the acromion, and we'll see why as we go through this talk, and all the way down to the proximal humerus on axials. When we're positioning the shoulder, we like to have some external rotation. And if you tell the technologist to do external rotation, they'll often, or supination, they'll often just supinate the hand. But as you know from positioning your hand, that doesn't do anything to your shoulder. So what we usually tell the technologist is to bend the arm 90 degrees, if you can do that in the scanner, put the arm on the body and externally rotate, and then put the arm down. And that will assure that the shoulder and the glenohumeral joint is external rotation instead of internal rotation. You can see what happens on internal rotation. The subscapularis gets all kind of buckled, and it can be difficult to see whether the biceps is subluxed. It's also important to get the appropriate oblique coronal and sagittal planes. We don't like to go perpendicular to the glenoid, although a lot of technologists do that. We generally like to go along the supraspinatus. So if you go up high enough on your axials, you'll see the tendon of the supraspinatus coming down. We generally like to go through there. And if you have done good external rotation, the supraspinatus will line up very nicely and will not be curved. Our oblique sagittals can be done parallel to the glenohumeral joint, but you need to follow them back medially because you need to see the bulk of the muscles to see whether they're atrophied. Now, a very important thing when you're protocoling studies and reviewing them for quality is coil positioning. And I think the number one problem I see with artifact and problems with interpretation and quality is malpositioning of the coil. And unfortunately, a lot of the shoulder coils are not really well designed. A lot of musculoskeletal coils are not well designed for the human body. And a lot of the shoulder coils slip off, or they're clamshell coils where the patient can slip out of them. And what you get is that the coil is positioned too far out laterally, and you'll see drop in signal to noise as you go medial. A good way to do that, as Dave Rubin has pointed out in the past, is to look at the scout image. That shows you the concentration of signal that will tell you where the coil was positioned. Now we'll talk about impingement as we go on to talk about the rotator cuff. And the first question we'll pull up here is, this finding is not thought to be a major contributor to shoulder impingement. Is that going to be a subacromial spur, an osteocromial, acromioclavicular osteoarthritis, or downsloping acromion? All right. So osteocromial was picked number one, and we have a good mix there. Most people thought subacromial spur is associated with impingement, which is really good because that's probably the major contributor. So we'll talk a bit about impingement now, then we'll get to that question. And what we're talking about with impingement is really in two forms. We're talking about primary and secondary impingement. Primary impingement is narrowing of the rotator cuff space, the subacromial space, where the supraspinatus and infraspinatus lie. Now, narrowing can be from a number of reasons, including subacromial spur, hooked acromion, osteocromial, downsloping acromion, and acromioclavicular osteoarthritis has been proposed, but it's very controversial, and I'll get into a reason why a lot of people feel like that is not a contributor to impingement. You can also get impingement in a secondary fashion related to instability of the glenohumeral joint, and we'll get into that later. Instability can be from labral tear, from glenohumeral cartilage loss, and other things like dysplasia and multidirectional instability. So let's talk about that subacromial space, where the supraspinatus and infraspinatus lie. This is normally a nice rounded space with a good bit of distance between the acromion and the humeral head. Now, positioning of the acromion can influence the space. Theoretically, acromioclavicular spurs can also narrow that space. But if you look at where the AC joint is positioned, the acromioclavicular joint and its spurs are positioned in the muscle of the supraspinatus. And here's the muscle of supraspinatus, here's myotendinous junction, and here's the tendon. So it's hard to figure how spurs here could cause tears here. There has been proposal that this could be related to vascularity and ischemia of the muscle and tendon. But most people feel that this is not a significant source for impingement. So the answer here is acromioclavicular osteoarthritis. We'll get into the other reasons now. Probably the most important finding is subacromial spur, and that can occur in multiple forms depending on where the spur is located. The spur can be anterior, purely anterior, related to the coracoacromial ligament, or it can be lateral or anterolateral, which is often related to downsloping of the acromion. It often takes a configuration of an elephant foot. And you can imagine this elephant foot sitting on this cuff tendon as you abduct, the tendon going into that spur, causing abrasion and eventually tears. Here's the spur at surgery. And I've been called into the OR to feel a spur with my finger, as I didn't call one. So I tend to overcall these when I look at the MRI. So if I see anything coming down toward the cuff, especially if there's cuff disease, I will call a spur. I like to go through the images on oblique sagittal and oblique coronal and correlate them. So here we have a little spur coming along the anterior aspect of the acromion. And here as we come forward, we have a spur extending around laterally. So I would call this an anterolateral subacromial spur. Notice there's also acromioclavicular osteoarthritis, but again, this is more proximal. Now, people have talked about hooked acromion as well as a source for impingement. There's different morphologies of the undersurface of the acromion, flat, curved, and hooked. This is controversial, however, and although theoretically an anterior hook of the acromion can lead to impingement as the supraspinatus is directly below that area, the question is whether this really exists. This is not me, but a transcript from Morrison and Bigliani proposed this as a source for impingement. But there's poor interobserver variability, and the hooked acromion, if you look in the literature, is often related to the acromioclavicular joint medially or a subacromial spur laterally, hence leading to the poor interobserver agreement. So the question is, does this really exist at all, or is it just a manifestation of a subacromial spur? So we tend to ignore the undersurface of the acromion these days, although some people still describe the morphology. However, downsloping of the acromion, most people feel, is an important factor in leading to impingement. If your scapula is tilted such that the acromion is pointing downward laterally, as you abduct your arm, the rotator cuff will come into that spur and the lateral downslope and lead to impingement. So this is highly associated with impingement, as you can see with the tear here, and this flat appearing subacromial spur. An ossicromial can also lead to impingement, and here we have an accessory ossicle at the anterior border of the acromion, and the important finding here is that this can hinge downward, narrowing that subacromial space, leading to impingement. So the next question regards ossicromial. If present, there should be a fibrous synchondrosis. Bone marrow edema is a normal finding. Can be seen as a triple acromioclavicular joint, or the ossicle normally fuses to the scapula before age 17. Which of those is correct? All right, and most people picked fibrous synchondrosis, and that's the correct answer. The os acromial forms from lack of ossification of the acromial ossification center, or lack of fusion of the acromial ossification center. And there's three separate centers of ossification. They start laterally and ossify medially as the patient ages. And here's some residual cartilage left in a younger patient. So this is what one of the last ossification centers to fuse. So if it's before age 21, generally don't call an os acromial. This can lead to what's called a double AC joint, not a triple AC joint. There's three kind of bones there. There's the scapula, the ossicle, and the clavicle. And if you look on the oblique sagittal images, it forms what looks like two AC joints. This is why you really need to go up high on the axials, because it's very easy to see if you go up high on the axial images. Also very nicely seen on the axillary view. Now, normally there's a fibrous synchondrosis, but notice how the anterior deltoid fibers attach to the ossicle and the posterior fibers attach to the scapula. When you abduct your arm, those fibers pull against the os and can hinge the ossicle downward into the supraspinatus. So eventually this can form an abnormal connection, a pseudarthrosis with fluid signal in the interval. And it can even separate and lead to development of arthritis there. Obviously, that causes more instability and more impingement. Bone marrow edema is not normal. It's a sign of altered mechanics and stress at that synchondrosis. So edema is not a normal finding and generally indicates that there is abnormal mechanics at the junction. So the answer is there should be a fibrous synchondrosis if you have an os acromial. The pseudarthrosis is abnormal and edema is abnormal. Now, when you get impingement, one of the first things we see is bursitis. So inflammation of the subacromial subdeltoid bursa leads to fluid in the bursa, sometimes complex fluid, and that can be a prelude or a coexistent finding with rotator cuff disease as impingement progresses. As impingement progresses, you get tendinosis of the supraspinatus followed by the infraspinatus. This can lead to thickening of the tendon or thinning of the tendon. If the tendon is thinned, we tend to call it attritional wear, usually related to subacromial spur formation. If it's thickened, oftentimes there's this intermediate signal, which we call mucoid degeneration. We reserve the word tear for when there's fluid signal in the tendon. So if this is intermediate, it doesn't approach fluid signal, we call it tendinosis. So the next question is about calcific tendinosis. Does this represent the deposition of calcium pyrophosphate? Is it unrelated to calcific bursitis? Is it most common in the infraspinatus? Or can it extend into bone? Which one is correct? All right, so all over the board here. So it represents deposition of calcium pyrophosphate. Unfortunately, that's a trick question. It's calcium hydroxyapatite. Calcific tendinosis, calcific bursitis is hydroxyapatite deposition. So the answer is can extend into bone. And I'll show you an example of that. So here's an example of calcific tendinosis and bursitis. This is in supraspinatus and the adjacent bursa, and this is in the subscapularis on the axial image. So it can occur in just about any tendon in the body. The supraspinatus is most common. Now it tends to form within a degenerating tendon, and if it's within the tendon, it oftentimes is asymptomatic, and it's hydroxyapatite deposition. If it's contained within the tendon, it's generally asymptomatic or can be asymptomatic. However, if it's large enough, it can block abduction of the arm. Now, when the calcium hydroxyapatite bursts out of the superficial aspect of the tendon, you get a crystalline bursitis, which is sudden onset, is very, very painful, causes crepitus or a grinding sensation and pain, and often focal tenderness. Patients can even have a low-grade fever. If it's in an unusual location in the body, it can even be mistaken for cellulitis, fasciitis, and other nefarious conditions. But in the shoulder, we tend to recognize it as what it is, calcific tendinosis and bursitis. It can extend into bone, and if it extends into bone, it can incite an inflammatory response in the marrow, leading to bone marrow edema. This can be mistaken for a tumor. So you just have to be aware that this occurs, and if you see low signal on all sequences at the insertion of a tendon, wherever it is in the body, just consider the possibility of intraosseous extension. So the answer is can extend into bone. It's most common in the supraspinatus. It is related to calcific bursitis, and it represents calcium hydroxyapatite. Now moving on to rotator cuff tears then, related to impingement. It's important to use the correct terminology. You want to document the tendon involved and the size of the tear, very important. I would avoid the term complete tear. A lot of people, surgeons included, use that term to mean massive tear. So if you're describing a complete tear of one tendon, just be sure to say that in the report, that there's a complete tear of the supraspinatus tendon. But it's important to describe it as a full thickness or partial thickness tear. That's the terminology that's used. A full thickness tear can be 1 millimeter wide, but it goes from the bursal side to the articular surface. So full thickness doesn't imply size, it only implies that it goes all the way through the substance of the tendon. A partial thickness tear can occur at the bursal side or the undersurface or articular side. So here's an example of location. So you want to identify location. You can compare on the oblique sagittal and on the axial or oblique coronal to identify the location. Here's the anterior portion, posterior, here's anterior and posterior. If you want to get a good rule of thumb about what is supraspinatus and what is infraspinatus on the oblique sagittal images, you can generally divide the head into half. And the anterior half of the head distally is the supraspinatus, the posterior half is infraspinatus. The teres minor is all the way down here, the subscapularis has already inserted. So this is what we call the anterior leading edge, or the most anterior portion of the supraspinatus, and that's where tears most commonly occur. This is not a pretty image. You won't see this in books generally because it's hard to see the anatomy. But the anterior leading edge is where most of these tears occur. Here you can see the anterior portion of the glenohumeral joint. Here's the biceps coming through. Lesser tuberosity, greater tuberosity. This is supraspinatus, and that's the most anterior portion of the supraspinatus right next to the biceps. That is the most common spot that we see tears. And why does that happen there? Because as you go into the hailing a cab position, you internally rotate and elevate the arm. And that brings your supraspinatus and greater tuberosity into contact with a subacromial spur or the anterior undersurface of the acromion. So that is the position you don't want to get into if you have impingement. Now, why do older people get so much rotator cuff pathology? Well, some of it is just history, degeneration over time, but a lot of it is related to scapular positioning. As we age, we tend to get kyphotic. As we get kyphotic, our scapula tilts forward. That tilts our acromion forward as well. And we go into that hailing the cab position, it's lower range of motion that causes impingement on the undersurface of the acromion. Here's a partial thickness tear. You see the bursal side is intact, the undersurface is torn. And you can see that the supraspinatus in this case is thinned diffusely, which I would call attritional wear. The undersurface tear has been called a rim rent tear if it occurs right at the insertion. You have to be aware that the rotator cuff inserts on a footprint. So it's a three-dimensional structure. Here are the deep fibers inserting here. Here's the footprint, and here are the superficial fibers. You have to look at the whole footprint. So this is a partial thickness tear, but it's what we call a hidden tear. It's an interstitial tear. So here's the deep fibers, here's the superficial fibers, they're all intact. This is an interstitial tear. It's called a hidden tear because if the surgeon goes in arthroscopically or over the top as an open procedure, they won't see this tear unless they open up the tendon. Bursal side partial thickness tears are not as common as undersurface and interstitial tears, but you will see them, in this case, with fraying of the surface at the bursal aspect. It's important to give the size of the tear. So here we see a full thickness tear. You see the entire footprint is uncovered. You see there's a little bit of a gap as the tendon is pulled back. You want to measure the size in 2 dimensions, the AP dimension and the medial to lateral dimension. I tend to avoid the R word. I tend not to call it retraction because a lot of times these are holes that are worn in the tendon, and retraction implies a bad prognosis. So unless the myotendinous junction's pulled back, I tend not to call these retraction. Here's what we would call a massive full thickness rotator cuff tear with the entire supraspinatus and infraspinatus torn. In this case, I would use the R word as this tendon is retracted all the way back to the glenoid rim. And you measure the retraction as well. In this case, the myotendinous junction's way back here, so this is true retraction. You can also get delaminations. Here's an example of arthrogram. Contrast extends into the substance of the supraspinatus, representing intratendinous propagation of the tear. Notice there's no contrast extending into the subacromial subdeltoid bursa, suggesting that this is not a full thickness rotator cuff tear. This can be seen on ultrasound as well. Here are the interstitial tear and the undersurface tear, communication from the joint into the substance of the tendon. You can also get formation through the same mechanism of an intramuscular cyst. And Tim Sanders described this very nicely in the journal Arthroscopy. When you see a cyst within the muscle, it often implies that there's been intratendinous extension from an interstitial tear or an undersurface partial thickness tear more distally. Here's an example of a lobulated cyst within the supraspinatus muscle more proximally. Here's the extension down the tendon to communicate with this partial thickness tear distally. Full thickness tears, you'll see communication with the bursa. So I tend not to call this bursitis when I see full thickness communication. This is an MR arthrogram. It's kind of overkill for diagnosing rotator cuff tears, but nicely demonstrates the full thickness component. Like I said, this can be very, very small. It's important to measure it to give the surgeon an idea of whether it's a surgically treatable condition. So you want to describe also whether the patient has a good or bad prognosis for repair. Bad prognosis is retraction, usually greater than 3 centimeters retraction or to the glenoid rim, a large tear involving multiple tendons, and muscle atrophy. So don't describe muscle size as atrophy, describe it when you see muscle fat deposition. It's also important not to rely that much on the oblique sagittal images. If the tendon is retracted, it may look like it's atrophied. So look on your T1 oblique coronal for true muscle fat deposition before you're calling atrophy, which makes the patient a poor surgical candidate. Here's osteoarthritis in a high-riding humeral head, what we call rotator cuff arthropathy. You can get muscle atrophy for other reasons. We often see teres minor muscle atrophy, which can be related to impingement of the axillary nerve in the quadrilateral space. However, most of the time we see this as an idiopathic finding. Now this can be important. I do like to describe it because if you want to avoid the impingement position, what do? You externally rotate the arm. External rotation of the arm causes the greater tuberosity to rotate back behind the acromion as you elevate. So if you have weak external rotators, of which teres minor is one, that can lead to progression of impingement. Now here's a massive rotator cuff tear. In this case, not only is the supraspinatus and infraspinatus involved, but also the subscapularis. So it's very important not to forget the subscapularis, to look there on all your axials. Now you can get other forms of impingement. You can get subcoracoid impingement. It's a little controversial. But if your coracoid comes around in a curved fashion, nearly abutting the lesser tuberosity, you can pinch the subscapularis between those two structures. And a lot of times on the axial images, you'll see that the coracoid comes extremely close to the lesser tuberosity. You can see associated cystic change and subscapularis tears. So this can be important to identify to the surgeon that there is a possibility of subcoracoid impingement as a source for the rotator cuff tear. This can be associated with supraspinatus tears as well. Another form of impingement is internal impingement. So let's ask about that. Is it most commonly seen in elderly patients? Is it associated with posterior superior labral tear? Is it best depicted on adduction external rotation? Or it mainly affects supraspinatus? Okay, so most people got this right, associated with posterior superior labral tear. It's actually seen not in elderly patients, but usually in athletes, usually people that throw. Overhead throwing activities can result in impaction of the posterior superior aspect of the humeral head on the posterior superior glenoid, leading to injury to both of those structures. You see a constellation of findings, including posterior superior labral tear, usually undersurface tearing of the infraspinatus, and often you'll see cystic change at the posterior aspect of the greater tuberosity. Now, I just warn you, though, that this cystic change can be a normal finding, so unless the patient's a throwing athlete or unless they have the other findings associated with internal impingement, I generally ignore those cysts. Here's an example of a high school pitching athlete with internal impingement clinically. They have undersurface tearing of the infraspinatus seen on the MR arthrogram and a posterior superior labral tear. So in this case, it's kind of a slam dunk for this diagnosis. This can be easily seen if you do abduction external rotation position. We usually do this to look at the anterior inferior labral capsular structures, but you'll see nicely the pinching effect if you look on the other aspect of the glenohumeral joint. And here is the posterior superior labrum and the infraspinatus, and you can see the impingement occurring there if you do that position. So the answer is associated with posterior superior labral tears. It's seen on abduction external rotation and usually affects the infraspinatus. Now, you can also get impingement related to instability. So we have to talk about glenohumeral stabilization. There are primary glenohumeral stabilizers and secondary stabilizers. The primary stabilizers include the glenoid cup, intact cartilage, which creates a suction effect, and the labrum and capsular structures. And this can be analogous to a jar that you can't open. A lot of times you can't open a new jar because there's a suction there. Well, that's what the cartilage and labrum do with the glenohumeral joint. It creates a suction effect. So how do you break that jar suction? Well, you deform the surface. You hit it with something. So if you tear the labrum or you injure the cartilage in the glenohumeral joint, that also reduces that suction effect and can lead to instability. Secondary stabilizers include the rotator cuff tendons as dynamic stabilizers, as well as the long head biceps, which is a depressor of the humeral head, and the deltoid and scapular muscles. So as you can see, the glenohumeral joint is set up for instability. It's like a golf ball on a golf tee. There's a wide range of motion at the expense of stability. So the rotator cuff really acts as a dynamic stabilizer. At rest, or at adduction, while the arm's by the side, these act as passive stabilizers holding the humeral head in position. But when you go into abduction, the rotator cuff muscles pull the humeral head into the glenoid, stabilizing it, causing it to rotate instead of translating. So if you have instability related to a cuff tear or related to labral damage, you can get the humeral head translating upward as you try to abduct, facilitating the impingement process. So instability can lead to impingement, but impingement can also lead to instability as rotator cuff dysfunction causes muscle imbalance and subluxation. So these things are related. There are two main patterns of instability called Tubbs and Ambry. Tubbs is traumatic, and usually you'll see a Bankart and Hill-Sachs, and results in unidirectional instability, whereas Ambry is referred to as multidirectional instability. It's bilateral, usually symmetric, although it can be asymmetric if you're involved with an activity like throwing. It's usually treated with rehabilitation. Here's an example of someone with posterior instability. They have a posterior labral tear. You can see the subluxation of the humeral head. Secondary osteoarthritis as the head is extending off the posterior glenoid. Labral tear and a paralabral cyst formation. Here's another example of a patient with posterior instability, in this case with rounding of the posterior glenoid rim, and you put stress on the patient and they pop out. Multidirectional instability you can see in patients with laxity. These patients are often double jointed. They can do crazy things with their limbs. And this capsular redundancy and laxity can lead to shoulder instability, and that can lead to secondary impingement as well. As I mentioned before, labral tears can also lead to instability. Arthropathies, if you destroy the cartilage, if you destroy the glenoid labrum related to rheumatoid arthritis or other conditions, that can also lead to instability and secondary impingement. Here's an example of a patient with amyloid, but this could easily be rheumatoid arthritis. Whatever the reason, if you destroy the cartilage and you destroy the labral structures and capsular structures, that leads to instability and can lead to secondary impingement. Glenoid dysplasia is rare, but see how there's no neck to the glenoid here? And that can lead to instability as well. Absence of the stabilizer can lead to secondary impingement. Now finally, let's just talk about clavicular osteolysis. This can be related to AC joint separation, may represent subchondral stress fracture, cause of resorption of the clavicular cortex, or all of the above. Now I put in clavicular osteolysis because this often mimics rotator cuff disease. And if you think about rotator cuff disease, how the patients present, they often present with pain as they go above the head, but they'll often present at night. They wake up at night because as they roll on the arm, it hurts. And the same thing can happen with acromioclavicular joint disease, especially clavicular osteolysis. All of the above is correct. So here's an example of what we see with clavicular osteolysis. You'll see edema predominantly or completely on the clavicle side. This is often related to weightlifting activities or to acromioclavicular separation. You'll often see a subchondral line. So the theory is that this might represent a subchondral stress fracture, analogous to SONC in the knee, transient osteoporosis of the hip, all thought to represent subchondral stress. Now, the same etiology occurs as in those other areas, overload and destabilization. Now, why would a subchondral stress fracture occur here? Well, if you think about it, this is the only connection that your arm has to your body. It's the only osseous connection the arm has to the body is that one little joint with 1 square centimeter of area. So if you're doing anything above the head, you're putting that concentration of forces across 1 square centimeter, which can lead to extreme forces across that subchondral bone, which can lead to a subchondral stress fracture. And that can be the etiology of osteoarthritis as well. So all of the above is the answer there. So just to summarize, factors leading to impingement: acromial morphology and tilt, subacromial spur formation, osteochromial, glenohumeral instability is secondary impingement, thoracic kyphosis, and thanks very much for your time today.
Well, thank you for staying. I'm going to talk about menisci. And I spent about half of my time doing clinical work at Walter Reed, and we really see a high volume of sports medicine injuries. So that's where this material comes from. I will do a little bit more of a case-based format. So I'll show you cases as we go through this, but I'll start with just a basic approach to menisci. These are the things we will try to cover, and I think I always do internal derangement lectures with the last thing: what does the surgeon want to know? Because that's really what we want to get across to our clinical colleagues. So the first case is a 25-year-old man with a twisting injury and knee pain. And I'm showing you these images. And here is the question. And I'm going to go to that. So what is the meniscal abnormality? Is it a discoid lateral meniscus? Is it a radial tear of the posterior horn of the lateral meniscus? Is it a vertical longitudinal tear of the posterior horn of the lateral meniscus? Or is it a horizontal tear of the posterior horn of the lateral meniscus? Good. So vertical longitudinal tear of the posterior horn of the lateral meniscus. So that is the correct answer, and we'll talk about that a little bit. Dr. Pathria touched on this as well. These are very common to be associated with ACL tears, both medially and laterally. And in fact, they may be repairable as well, particularly if they're in the peripheral third of the meniscus, which is the vascularized zone, which in fact, because it's vascular, can heal on its own. And we can see pictorially that this divides the meniscus into inner and outer components. If we look from above at the meniscus, and the meniscus is basically a shock absorber, we can see what we can identify with a vertical longitudinal tear. And because one of the major jobs of the meniscus is to act as a shock absorber and to dissipate forces, equilibrate them to bone, we can see that when we have that vertical longitudinal tear, there are still inner and outer portions of the meniscus that can in fact do their job, that can in fact dissipate those forces. And when the surgeon gets in, they can take out that inner or outer portion and leave the remainder of the meniscus. So one of our most important roles is to really not only identify tears, but to differentiate what kinds of tears, because that's going to what's really going to tell the surgeon what kind of surgery is going to be optimal. And they want to be able to warn the patient what kinds of surgical interventions are appropriate or are possible. It's different than 40 years ago. 40 years ago, they just take the meniscus out. I have a good friend who's a musculoskeletal radiologist that unfortunately had this happen 40 years ago. And he's having a total joint replacement in January because they just took out his meniscus. So certainly very different. Their job is to preserve as much meniscus as possible because of that relationship. So the meniscal function is to dissipate those forces. It's an expensive shock absorber. I actually many times like to think about it as a squeegee. When you walk, you're squeezing that water out and you're dissipating those forces equally to the bone. But unlike a shock absorber we can get replaced by going to a car shop for $300, we can't do that with our meniscus. And certainly the other functions are shown here as well. So if we look at the meniscus from above, what happens when we walk is we are dissipating those forces, and frequently that's termed the hoop stress phenomena with our meniscus. If we look microstructure of the meniscus, we know it's made up of collagen and there are circumferential bundles, but there are also tie fibers that interconnect the meniscus. So this is the typical major portion of the collagen, the circumferential fibers. And those are the tie fibers that add strength to our meniscus. So what we're going to talk about is different kinds of tears, and these are the basic kinds of tears. So our job is not only to identify the tear, but also to identify what kind of tear it is, because today it has an implication on the ability to repair those tears so we don't get that premature degenerative disease or osteoarthritis. So here is another vertical longitudinal tear. We can see it quite nicely. This would not be in the vascularized portion of the meniscus. This would be in the white zone, and so it would not have potential to heal on its own. When we have peripheral vertical longitudinal tears, those again may be in the vascularized portion of the meniscus. They may have an ability to heal on their own. So here is an example of that, and the example we looked at as well. Probably the first 3 or 4 of these I saw 2 or 3 years ago, I missed. What I often like to say is they were seeing me, I wasn't seeing them. And these are important to identify. And the problem is when they occur posterolaterally is, why isn't that just fluid along the popliteus? Right? Why isn't it just fluid? And what we really need to look at is that vertical line extending from top to bottom, so it's touching the free edges. Notice there is meniscal tissue behind there. And there's our popliteus, and there's our sheath. So that's what you need to look for. Those are also potentially, they may heal on their own, because that is the red zone of the meniscus. So that's what we need to look for. These are commonly associated with ACL tears. Does this person have an ACL tear? Absolutely. You have the pivot shift contusion pattern. I will tell you, your surgeon will be more interested in the meniscal tear because they already know there's an ACL tear. They are actually better than we are at testing for cruciate ligament tears. They're much more interested in fact, whether there is a meniscal tear or cartilage damage. Now, the other thing that they can do is they can put a suture around these, so it's total meniscal preservation as they put that figure 8 suture and tie it tight as well. So that's important also. If they go in and repair the ACL tear, these can also over time become unstable. So it's very important to direct them so when they're doing their ACL repair, they pull on that meniscus, they probe underneath it, and that's a difficult area for them to get to, because if they don't repair it at the time of that initial surgery, what can happen 3 months after the ACL repair, it can become displaceable. And then they'll come back in with a locked knee. And that's a disaster because now the patient needs a second surgery, and they may have destroyed that meniscal fragment as well. So you really want to alert them to those vertical longitudinal tears. So which of the following is true concerning this tear? Should be easy, right? Oops. Now it's really easy, right? You won't get this right only if you're asleep because I just flipped to the answer, right? All right. So 29% of people were not awake, right? So it's not in the white zone, right? It's in the red zone. And because of that, it has ability to repair on its own. Many people today would say these tears often have high signal in them because of the distraction acutely. And that will tell you it's an acute tear as well. When they heal, they'll start to get gray signal in them or even low signal within them. And then when the surgeon pulls in them, if they're healing, they won't displace. And they probably don't need to be treated either. Is it frequently associated with PCL tears? Well, we know that's not true. It's with ACL tears. And over time, they can become unstable. So that's why the surgeon wants to address them at the time they're also addressing the ACL tear. So in 1982, Dr. Onosky did microvascular evaluation of the menisci, really telling us about these red and white zones. And if we look at the inner 2/3 of the meniscus, it is avascular, and that means it has limited ability to heal itself. But if we look peripherally, that peripheral third of the meniscus is vascularized, so it has potential to heal itself. And we have to tell our surgical colleagues where the tear is. Is it in the white zone, or is it in the red zone? Now, similarly to vertical longitudinal lateral meniscal tears, we can see the same thing, Dr. Pathria touched on this, medially. And it is also often associated with ACL tears, almost a contre coup kind of injury. So if we look here, we can very nicely see in this patient with an ACL tear the same features. And how do we know that's a meniscal tear? Notice the black signal, the meniscal signal peripheral to it. So this is a peripheral vertical longitudinal tear in the red zone of the medial meniscus. The other thing that's very helpful is look for your bone contusion. You know forces were dissipated there because there is contusion there as well. And that's very helpful to hold our hands, make us more confident that we're dealing with a vertical longitudinal tear, nicely shown here. If it's even more peripheral, we can have meniscocapsular separations in that loose areolar tissue between the MCL and the meniscus. And this is an example of one of those. It's important not to overcall those. I really want to see water signal in that region. And I think most literature is telling us that those typically are stable. They will usually heal on their own, unlike the peripheral vertical longitudinal tears that may become unstable over time. And here is an example, again, of a meniscocapsular separation. You can see that separation and the peripheral vertical longitudinal tear as well. So the second case is a 58-year-old woman with severe knee pain. And these are the images. You can advance to the one that has the images on. Oh, there it is. So what is the meniscal abnormality? Discoid medial meniscus, medial meniscal root tear, vertical longitudinal tear of the posterior horn of the medial meniscus, or a horizontal tear of the posterior horn of the medial meniscus. I think I have the timing down now. All right, a little better question because we're just separating out the answers. And the right answer here is that this is a medial meniscal root tear. And this is an important tear not to miss. And we'll talk about that as well. So if we talk about this case, again, this is the right answer. This is a medial meniscal root tear. The meniscal roots, there are both anterior and posterior roots. We tend to concentrate on the posterior roots, and there were several talks about the roots both anteriorly and posteriorly, and some people may now refer to them as the meniscal root ligaments. The posterior roots attach the meniscus to that midline. And so on posterior images, as is shown here, normally on the left side, you should always see meniscal tissue on your two most posterior images through your meniscus extend toward the base of the tibial spine. Typically, as is shown here, the medial meniscal root turns down and the lateral meniscal root turns up, and posterior horn meniscal root tears are much more common medially, and they are radial tears. So we talk about signal intensity touching free edges for meniscal tears. We also need to understand that morphology is just as important, and that's why we have to know normal so we don't miss these abnormalities. Because if we look in this case, that's the abnormality. We must know that the meniscus should extend more toward the midline, near and over that tibial spine, because we can see it match to the normal here. Now, if we look, the other way you see it, I often look at my sagittal images first, is you will start to lose your meniscus as it starts to trail underneath the posterior cruciate ligament. And it still should look like a pretty good sideways triangle, and the circle is on my sagittal images where that posterior root is abnormal, because I should see meniscal tissue on that image. And I actually find axial images very helpful often for meniscal tears, because it won't show me the tear, but it will show me the morphology, what type of tear I am dealing with. And we can very nicely see this radial type tear in the posterior horn of the root of the meniscus. Now, the reason these tears are important is because they make the meniscus more mobile. And these tears can have implications, and some of these patients will rapidly develop degenerative disease. Now, while there are multiple surgical techniques, newer ones being developed to try to address this with an anterior portal, the posterior portal may have to be done to address this kind of tear. How excited are orthopedic surgeons to do a posterior portal? What's back posteriorly? Big red, big blue, and big nerve, right? So there are more complications to posterior portals. So it's important because it may change how your surgeon addresses this tear, and it may have dramatic implications as well. So here is what the meniscal root should look like on sagittal images. We can very nicely see that meniscal root. You should see meniscal tissue underneath that PCL. Don't call that a double PCL sign. We're going to see that up here, not inferiorly, where we see the normal meniscal root. If we look coronally, again, we should see that meniscus medially, usually turning down, going toward the base of that spine on our one or two most posterior images, and you can see where you are on your axial gross image and on your coronal image, and then the matched MR image as well. So there is your meniscal root. You should always see one or two images with that appearance most posteriorly. Here is another question, because this is a patient with a meniscal root tear, and then they came in with a lot of pain. And here is your question. What complication of a meniscal root tear has occurred in this case? Is it avascular necrosis? Is it osteoarthritis? Is it an ACL tear? Or is it a subchondral insufficiency fracture? Okay, everybody did great on this. This is a subchondral insufficiency fracture. That is the right answer. And we can see that cleft of low signal right underneath the bone, and then tremendous edema around it as well as the associated joint effusion. And what can happen with these meniscal root tears when your meniscus now has more mobility is you change, you've lost some of that shock absorber effect, and when that happens, what has to take up for that increased stress, or that stress, is your bone will be exposed to that increased stress. But your bone can't handle that increased stress, particularly if you're older and a little osteoporotic, and it will fracture under physiologic stress when your shock absorber is no longer there. So that's the process that occurs. And it is interesting that these patients may be able to tell you, my pain is severe. It started on Thursday as I was walking up and down the halls at the RSNA, and it's horrible and I can't bear weight anymore. And they are describing to you when their insufficiency fracture actually occurred. Now, we used to call this spontaneous osteonecrosis. We now know most of these are insufficiency fractures, so we used to call it SONC, although I tended to call it SPONK just because I thought that was cooler, in fact. Notice the tremendous edema, which is why these patients are often severely painful. So again, a little information about that. They tend to occur in women older than 55, acute, abrupt onset of pain. These may well heal with conservative therapy, but sometimes they will truly go on to collapse. And here is a very unfortunate case where that happened. Initially, the x-ray looked normal. 3 months later, you can see that flat articular surface. There is a reason tires are round, correct? They work better that way. When they are flat, they don't work very well. And you can see that flat articular surface, so you can't glide from your femoral condyle over your tibia. And you can see dramatically 6 months later, the marked collapse also nicely shown here. And we know what's going to happen in this case. They're going to need an arthroplasty, either a hemiarthroplasty or a total arthroplasty with that severity of collapse, really initiated by their subchondral insufficiency fracture. The third case is a 73-year-old with a fairly large mass and knee pain. These are the x-rays. Multiple MRs. The top row is T1. The middle row is T1 post-contrast, non-fat suppressed. And the lower row is T2 without fat suppression. Here are axial images the same. The top row T1, middle row T1 post-contrast, and lower row T2 non-fat sat images. And here is the question. What is the correct diagnosis? Is this a meniscal tear with a meniscal cyst? Is it osteoarthritis with an abscess? Is it a ganglion? Is it a septic joint with an abscess? So there were image slide with those images on there, but yeah, you repeat. Can you do that? Can you restart? A do-over? Because I think, okay, there you go. Because there were a lot of images here. Can you restart the 20 seconds? Thank you. So again, what is the correct answer? Meniscal tear with meniscal cyst, osteoarthritis with abscess, ganglion, or septic joint with abscess. Difference in therapy depending on what you answer? Clearly the answer is yes. All right, great. The vast majority of people got this correct. 2/3, this is a meniscal tear with a meniscal cyst. But there's a follow-up question. How sure are you? And why? Or does this need to be biopsied? So, There's no image here. Yes, I'm sure, because I said so. No biopsy is indicated. A classic staff answer at an academic center. Clearly, I didn't say that. Yes, I'm sure, because there's air tear and it's peripheral enhancement. No biopsy is needed. Yes, I'm sure, but I don't know why, so biopsy to exclude badness, infection. No, I'm not sure, so biopsy it. All right. Great. Well, that's the right answer. That's what we said, in fact, as well. This may be the one of the biggest, if not the biggest, meniscal cyst I've ever seen at the knee anyway. What we can see is the irregularity of the osseous surface, and there's some multiple lucencies there. What are those lucencies? They're very lucent, right? In fact, they look like air or gas, which might make you think about infection, other than the fact the bone response looks like it has been there for a while, and that's actually nitrogen that's leaked out because of vacuum phenomena and showing us we have communication with the joint as well. And we can see the marked loss of joint space really in the medial and lateral compartments in this case. We can see the mass quite nicely, and if we look at the medial compartment of the joint, there basically isn't a medial compartment. We have a macerated tear of the entire medial meniscus, and in fact probably the lateral meniscus as well. We can see the low signal on the T1 weighted image, and we can see the total loss of joint space in the abnormal diffuse meniscus. Notice the connection to the two, which we can clearly see that there is a tract coming from the joint connecting it to this mass. The low signal areas represent what on the X-ray? The gas, right? And that can be easy to miss on MR if you don't have X-ray correlation with the area. And we can see it perhaps to better advantage on the axial images where the regions of very low signal intensity represent the gas formation intermixed in the mass. If you thought that was a gas-forming organism, one of the problems with that is there any edema around this at all? And the answer is there's no edema. And if you thought this was an abscess, you would certainly think, non-treated, that you would see a lot of inflammatory reaction around it, which we in fact do not. So we know we can have lots of associations with meniscal tears, many of them listed here. When we see meniscal cysts, those are almost always associated with meniscal tears, with one exception, and that's locules located anterolaterally. Because there is a normal bursa in that region, make sure you can actually identify a tear in that anterior horn, and it's a rare spot for a tear as well. So otherwise, usually we are dealing with a meniscal tear. Now the classic tear would be shown here with a horizontal tear, and then that fluid pulses through that tear and accumulates in the cyst, much smaller than the one I just showed you. The fourth case is a 35-year-old. We saw this case within the last 6 months. A colleague, she's an anesthesiologist. She presented to the ER with a locked knee after an injury. And I show you these images and these images. Go to the next one. Okay. What is the meniscal abnormality? Radial tear of the medial meniscus, medial meniscal root tear, vertical longitudinal tear of the posterior horn of the medial meniscus, bucket handle tear of the medial meniscus. Okay. I just don't have the seconds. Okay. Alrighty, great. Everybody got it right, 95%. This is a bucket handle tear of the medial meniscus. Displaced tears are important, and they can be displaced with the classic handle of the bucket, as is pictorially shown here, but we can have other displaced tears as well. Now, bucket handle tears are usually better seen, as are most displaced tears, on water-sensitive sequences because the fluid surrounds it, and we know we can look for these abnormalities, and I've given you sensitivities for both too few bow ties and the double PCL sign, both of which were shown in this case. Now, your images far peripherally with a bucket handle tear may look relatively normal, although if you're at the edge, you will see areas of increased signal touching a free edge. Now, I personally am not a bow tie guy. I don't use the bow ties very often when I dictate, and I don't wear bow ties either very often. As you march more and more toward the intercondylar region, you will see more deformity because you've lost meniscal volume. This is really a vertical longitudinal tear, but now it's displaced into the intercondylar notch. As we get more and more toward that interregion, we will see blunting of that posterior horn, but now also the anatomy is important because it looks like the anterior horn is way too big. So we have to understand, normally on the medial side, the posterior horn should be bigger than the anterior horn. Where has that meniscal volume we've lost gone? And we can very nicely see that as we move more and more toward the intercondylar region because we're seeing the handle of the bucket. The PCL nicely shown here, and there's our double PCL sign because we know we should only have one PCL. In the coronal plane, our far posterior images may look relatively normal. Here we're probably at the edge because we are seeing a little abnormality that's touching a free edge. As we move more toward the body of the meniscus, we will see blunting because we've lost meniscal volume because of its displacement. So again, our job, once we see the abnormality, the tear, is to find where that piece went, and they always go into the intercondylar region. We can see it quite nicely here as well. Arthroscopically, this is important, and you can see this bucket handle tear, this displaced fragment, very nicely at arthroscopy. As you get more anteriorly at the junction between the bucket and the remainder of the meniscus, you may see the cleft, as is nicely shown here, with high signal. Don't forget your axial images. I find them very helpful in many cases, not so much to identify a tear, but in fact to see what kind of tear it is. And usually I think classic signs never look like they were described, but this actually looks like the handle of the bucket displaced into that intercondylar region. You can see the whole thing on the axial images. Now, there are multiple other types of displaced tears. Here's a pretty common one where the posterior horn of the lateral meniscus is flipped forward on a pedicle, and if we look at the image, the abnormality is that the posterior horn morphology is grossly abnormal and distorted because laterally we know the posterior horn should be very similar in size to the anterior horn. There is the normal anterior horn. There is that flipped piece, and it's rotated 180 degrees as well, and that little gray signal there is between the two pieces. So this is also a displaced meniscal tear. And again, look at your axials. They can be quite helpful. There is the normal anterior horn. There is the cleft of fluid or granulation tissue between the pieces, and there is that flipped piece forward as well. Another area that can be blind for your arthroscopy colleagues is when a meniscal fragment is flipped into the meniscotibial or meniscofemoral gutter. These are horizontal tears and then flipped on a pedicle, as is nicely shown pictorially and in this case as well. Here, from a case lent to me by Dr. Kurt Davis, you can see them retrieving that displaced fragment also. And here's an example we had last week at our institution with that flipped piece. And again, notice the first thing we should identify, we don't have a sideways triangle. We have that piece flipped down from the tip. That can be a blind spot for your arthroscopy colleagues. It can be difficult for them to identify. And I have two video clips. And you're going to see that big piece. There it is, flipped forward, and there is the meniscus right there from where it came. And I have one other video clip. You're going to see them actually probe this so they can flip back and forth sometimes. Notice how they're going to probe that, and they're going to be able to actually pull it out. That's what your arthroscopy colleagues are seeing. And then if it flips into that gutter, if they don't recognize that, the patient may wake up after their meniscal repair and not be better. And that's not a good situation for any of us, not our patients, not our clinical colleagues, and not us. And you can see them pulling it out as well. Right there. Very nice. So, last question here. What do you do next? Dictate the case and move on. Share the nice case with your colleagues. Call the clinicians as this is an urgent finding. Get images for a future conference. All of the above. Right? Oh, now I've got the clock. All right, great. Call the clinicians because this is an urgent finding. We try to call all the time if we have a displaced fragment because the clinician wants to get to it earlier. Generally, they want to get to a displaced fragment within 1 to 2 weeks. Not like another meniscal tear where they can just fit it into their schedule. Why? What's the job? Preserve as much meniscus as possible, right? What if you walk around on a displaced fragment? What happens to that fragment? You chew it up, right? And then you're going to have to take more meniscal tissue. That's why it's important. If a patient comes in with a displaced fragment and a locked knee, that is as close to a surgical emergency as you will get in sports medicine. Other than a compartment syndrome, other than a dislocation with a popliteal artery tear. They want to get to that within a day or two. In fact, we saw this case on Thursday. They took this case to the OR on Saturday. Why? If you have a locked knee, you get arthrofibrosis, and that's a problem surgically. So that is a surgical emergency. You do want to call your clinical colleagues. It is also something that's frequently associated with a chronic ACL tear. And this patient, in fact, had a chronic ACL tear. You can see that where it should be the ACL filled with fat. So this patient had a chronically unstable knee and that displaced tear as well. So what does the surgeon want to know? They want us to identify the tear. Not only that, they want us really to identify where the tear is, what kind of tear it is, because that's going to really direct their therapy. And they want to relay those thoughts to their patients as well. I didn't talk about the slice rules for how we look at it, but basically if you see signal touching a free edge on 2 or more images, very confident you are dealing with a meniscal tear. Called the 2-slice rule. You're going to be over 90% for accuracy. If you only see it touch on 1 image, and you can't cheat, you can't use the sagittal proton and the matched sagittal fat suppressed image, that's still 1 image, right? If you only see it on 1 image, we actually will put on our reports that is a possible meniscal tear. That will be seen at arthroscopy immediately, only about 50% of the time, laterally only about 30% of the time. What if you look at your images and it's Friday afternoon and you're tired and you kind of sort of think maybe it touches a free edge? What do you do with that? We call that, or used to call it, the iffy meniscal tear. If you have to work that hard to change the contrast, I like to make the New Jersey rule. Forget about it. That's not a tear. It will not be a tear at arthroscopy if you have to work at it that hard. I've also tried to say we need to describe what kind of tear we're dealing with and be very careful about displaced tears. I say we call, you know what that means, right? That means the resident or the fellow calls. Why are you using the we term there? But it's important to get a hold of them. So I want to thank all of you for being here on this late Friday. I want to thank my colleagues also for their wonderful presentations. I hope you've had a great and wonderful time here at the RSNA, and I hope this has been educational for you. Thank you very much.